Got this one. Yeah, 1, 2, 3, audio test. 1, 2, 3, 4, energy and commerce. 1, 2, 3, audio test.
Good morning. The subcommittee will come to order. Chair will recognize himself for an opening statement. Today's hearing will examine legislation designed to modernize the current health insurance market by empowering states to better regulate markets tailored to their unique conditions. Previously, this committee examined healthcare solutions that centered on promoting patient choice and innovation in the design of health coverage. This hearing is a natural follow-on to that. Current law is leading to an increase in healthcare premiums. Double-digit premiums increases are hurting, not helping patients. It's no surprise that a recent Gallup poll revealed that healthcare costs top American families' financial concerns. Almost daily, headlines across the country offer frightening news on healthcare cost. This undoubtedly is contributing to the fears of the American people, and here are some of the numbers. In Virginia, 9 insurers are looking to raise premiums as high as 37.1%. 3 of the requests in Oregon are over 29.6%. One plan in New York is asking for a shocking 89% increase. For Texas, the biggest plan wants to raise its rates 60%. In Colorado, Golden Rule is seeking a 40.6% hike. Rocky Mountain HMO seeking a 34.6% boost, and Colorado Choice wants a 36.3% increase. Connecticut has 3 plans wanting increases from 12 to 27%. In my home state of Pennsylvania, one insurer is seeking a 48% increase, while the insurance department says the average request is 23.6% for individual plans. And this is why we're here today, to offer better care at a fairer price. Our solutions aim to help patients stabilize the insurance markets, restore flexibility, provide more choices, and keep cost in check. Healthcare is the most personal of any political issue. When Congress gets involved in health policy, we're changing people's lives. Decisions we make in Washington can have a tremendous effect on the well-being of families and their budgets. States, on the other hand, are great innovators, and when given the flexibility to tailor coverage and conditions, patients are the winners with greater choices and more affordable options. The 5 bills before us today offer a variety of options to begin to reduce cost, including the Flores bill to align grace periods, the Blackburn bill, which requires eligibility verification, the Brooks bill, which adjusts age rating ratio for health care pricing, the Griffith-DeGette bill that allows individuals and families to purchase standalone dental plans, either on or off the exchanges, and the Rick Allen bill, which establishes an audit process for failed state exchanges. Any unallocated or misspent federal funds would be returned to the U.S. Treasury. The first thing health reform should accomplish is to stabilize or reduce the cost of health care. The number one complaint people have about health care is the rising cost. Yet, the current law has done little to decrease health care spending. In fact, many Americans are paying higher premiums and deductibles for health insurance and care as a result of the law. We can do better. We must make health care costs more transparent, give people the freedom to choose the insurance they want, with the benefits they value most at a price that is fair. More government bureaucracy, regulations, and spending never successfully reduce the price of health care. Yet, that is exactly the premise of how health insurance is regulated today, with top-down mandates that empower Washington and remove control over health care decisions from states, small businesses, families, and individuals. And this has to be changed if we truly want bottom-up solutions that provide better care at lower costs for patients. The bills before our committee today will do just that. Is there anyone seeking recognition on our side? With that, I'll yield back and recognize the ranking member, Mr. Green, 5 minutes for opening statement.
Thank you, Mr. Chairman, and I agree that the increases that are requested, although having served as a state legislator in Texas in the 70s and 80s and the very early 90s, I think we saw the same request of course, the health insurance market was not regulated in the state of Texas, but as a small business manager, we saw 25, 30% increases over the years. So increase in health insurance costs is not new to the American public. Prior to the Affordable Care Act, the individual market on health care was deeply broken. People were sold junk plans at high cost. Individuals with pre-existing conditions were essentially locked out of the market altogether. Women would be charged more just because of their gender, and plans could drop you at the moment you got sick, the time when you need the coverage the most. 3 years after the Affordable Care Act, major health expansion went into effect. Approximately 13 million people have coverage through the marketplace, and 15 more through coverage of Medicaid. Since the law was enacted in 2010, 20 million more Americans are no longer uninsured, and the uninsured rate is at a historic low. Both the newly insured and previously insured are protected from the worst abuses of issuers, and what plans must cover is significantly more robust than ever. Overall, the coverage expansions are improving Americans' access to health care. The marketplaces are competitive in creating value for customers, and premium stabilization programs are working. The evidence is clear is that the ACA is a success. The majority of people enrolled in marketplace plans or Medicaid report that they would not have been able to access or afford their care prior to getting their new insurance. It's important to recognize that marketplaces created under the Affordable Care Act are in their relatively infancy. As with any or almost every new market, particularly in the healthcare space, there will be changes and adjustments in early years. Insurers will both enter and exit as they navigate the landscape to the millions of new consumers, protections, and requirements. Medicare, when it was first created, experienced growing pains, as did Medicare Advantage and Part D plans. The Affordable Care Act is working, but like any law, it's not perfect. As I've said, been known to say, if you want something done perfectly, don't come to Congress. And that's why after passing major reforms, Congress revisits legislation coming together and improve on it. Of the 5 proposals we're considering today, aligning children's dental health coverage stands out as a bipartisan bill that's improved pediatric dental coverage. I'm supportive of this legislation and appreciate the committee is paying attention to this important technical fix for children. However, I'm concerned that this bill was included in a legislative hearing evaluating several more controversial and I think irresponsible plans. The other legislative proposals we're considering today constitute a step backwards for consumers by forcing people out of the exchanges, make it more difficult for consumers to access affordable coverage using premium tax credits. We should be looking for ways to make the law work better on behalf of the American people rather than roll back reforms and protections designed to get more value from hard-earned dollars spent on coverage and put insurance back in charge at the expense of the consumers. Making it easier and more attractive to get coverage, expanding Medicaid, targeted outreach. These are ways to bring more stability and affordability to the health insurance market. Instead, most of the bills we're considering today will make it harder for people to get coverage, more expensive for people who need insurance, or only serve to help insurance companies rather than people. Health insurance is a product that Americans want and need, and the Affordable Care Act is creating a system that lends truth to the principle that health care is not a privilege for the few, but a right for all Americans. And while I welcome productive conversation on how to improve and make the ACA even better, we must not do anything that would undermine the progress that this important law has already made. And I look forward to hearing from our witnesses, Mr. Chairman, and I yield back.
Chair, thanks, Sheldon. Now filling in for the Chairman of the full committee, Dr. Burgess. 5 minutes for opening statement.
Thank you, Mr. Chairman. And this is a very good hearing for us to be having right now, and I'm very grateful that you've called it. I'm very grateful for the members that have participated and provided us bills for consideration today. We've got an excellent panel of witnesses in front of us this morning, with whom I have either agreed or disagreed over the years, but I know them to all be the best of the very best in healthcare policy, and I'm looking forward to their testimony this morning. Regardless of how you feel about the Affordable Care Act, I don't think there's any question that the fractures are becoming apparent and they are growing. And somewhat ironically, at the very last weeks of the Obama administration, these fractures are likely to become fractures, and real people are going to be affected by those fractures. it is important that we be talking, and we be talking now, about what we can do to help people when those inevitable failures do occur. The bills in front of us today make significant moves towards fixing some of those problems, but I'm also anxious to hear from our witnesses what they see when they look over the horizon, not just for next year, but the year after, the year after. If something does not change, the likelihood that we will have some very profound and real difficulties within the insurance market, within the provider space, and of course for patients themselves in this country. So, Mr. Chairman, I think you are to be commended for holding the hearing today. Certainly you've put a great panel of witnesses in front of us, and I will now yield to one of the authors of the bill, Mr. Griffith from Virginia, for his comments.
Thank you, Mr. Chairman. Thank you, Mr. Burgess. I appreciate that very much. I just want to let folks know that my little bill, along with Diana DeGette, 3463, will in fact level the playing field by applying the same rules to coverage options for dental care offered on the exchange and off the exchange. Currently, unfortunately, the way the language has been interpreted, you can buy a standalone dental plan if you're in the exchange, but if you're out of the exchange, it has to be wrapped into your health insurance, and oftentimes parents want to buy a better pediatric dental care plan for their kids than what's offered in a basic health plan. And so this bill would allow them that option and allow them to go out and buy a standalone dental along with a health insurance plan that otherwise qualifies except for the dental portions, so that they're not just having their children's dental care taken care of after deductibles are met, or taken care of for cleanings, but not for filling cavities, et cetera. I think it's a good bill, and I appreciate Mr. Green saying that they recognize that it's an attempt to fix a little glitch and is a bipartisan bill. And with that, I'd be happy to yield to anyone else that wishes time.
Anyone? Up inside,
Seeing
seeing
none,
time without.
I yield back to Dr. Burgess.
Chair, thanks, gentlemen. Now recognize the ranking member of the full committee, Mr. Pallone, 5 minutes for opening statement.
Thank you, Mr. Chairman. Congress passed the Affordable Care Act to ensure that all Americans had access to affordable, quality health insurance, and the goal was to achieve universal health coverage. 6 years later, our uninsured rate is at an all-time low, and our uninsured rate among young adults has dropped by 47%. 20 million more people now have health insurance, and a new University of Michigan study shows that the ACA has reduced racial and ethnic disparities in coverage. And this is all good news, but we have a lot more to do. I believe there are ways we can strengthen and improve the law. However, I'm concerned that this hearing is taking a cynical approach to doing so. Rather than have a legislative hearing on bills that would help get more people health coverage, 3 of the bills being discussed today are designed to make it more difficult for people to get health care coverage. One of the bills we're reviewing today would allow insurance companies to charge premiums that are 5 times as much for older Americans. Even more troubling, under this bill, a state could establish an age ratio even higher than 5-to-1. Many older Americans can't afford to pay 5 times as much as people who are younger than they, and we purposely included in the ACA ways to ensure that younger people have access to health insurance, such as staying on their parents' plan until the age of 26. So I'm concerned this will force older Americans to go without coverage at a time when they need it the most. There are also potential unintended consequences. Studies have shown the 5-to-1 age rating band overcharges older consumers and undercharges younger consumers. Meanwhile, the increased tax credits to accommodate these higher rates for older Americans could cost billions of dollars. Another bill we're reviewing today would make it more difficult for people to enroll in coverage during a special enrollment period, known as an SEP. SEPs are necessary for people to enroll in coverage when something changes in their lives outside of the open enrollment period. It's important for SEPs to maintain some flexibility so that individuals can get coverage in a reasonable amount of time as they transition through important life events such as the birth of a child, a marriage, or a permanent move. We've heard from insurers that SEPs aren't strict enough and are subject to gaming, and that's why the administration has taken major steps to prevent this. They have eliminated 7 SEP categories and now require documentation to prove SEP eligibility for the 5 most common life events. In addition, starting June 17th, CMS will require individuals asking to enroll in coverage through an SCP to provide documentation by a specific deadline. The individual will lose their coverage if the appropriate documentation is not received in time or is incorrect, and these are reasonable guardrails. Yet, although CMS is implementing stricter verification requirements, this bill goes a step further and requires someone to prove their eligibility for an SCP prior to gaining coverage. And I'm concerned that collecting and submitting this documentation may prove difficult and could lead to gaps in health coverage. Cancer patients can't wait a month to get the health treatments. In addition, the Urban Institute estimates that fewer than 15% of people eligible for SCPs use them to enroll marketplace coverage, and the rest are likely to remain uninsured. So I worry that stricter documentation requirements could deter all but the sickest individuals, since they're the most motivated to get coverage, while healthy individuals may choose to remain uninsured. And creating more barriers to access is only going to serve to keep more people out of the insurance market. I'm also concerned by the bill that would shorten the grace period for those lower-income Americans who qualify for tax credits. Grace periods were put in place because many of the people who are signing up are doing so for the first time. That population that is eligible for tax credits is also lower income and has more fluctuation in income, which is why we wanted to give them a chance to keep their insurance as part of the ACA. And under the bill before us today, just one missed or partial premium payment would result in someone losing their coverage until the next year, and this isn't good for consumers. I think I'll yield. I have less than a minute left, and I'd like to yield that to Ms. Matsui.
Thank you, Ms. Pallone. Because of the passage of the ACA, millions of American families have access to affordable quality health care, and our country's overall uninsured rate has fallen to a historic low. We've come a long way from the days when patients were denied care because of pre-existing conditions, and young people were left without coverage as they searched for employment. There is much we can and should be doing to build on the success of the ACA and keep moving our health system forward and ensuring that patients get the right care at the right time in an efficient way. We can continue looking at models of care that reimburse value over volume. We can infuse technology into medical practice and more. Some bills we're considering today would unfortunately reverse some of the important progress we've made. I oppose any legislation that disrupts the continuity of care for patients. As families seek health insurance, we cannot make the process more burdensome for them by asking them to jump through unnecessary hoops. I hope that instead we can continue to build on the progress of the ACA in a way that benefits American families. Thank you, Mr. Chairman. I yield back.
Chair, thanks the gentlelady. As usual, all the members' written opening statements will be made a part of the record. I have a UC request. I'd like to submit the following documents for the record: statements from AARP, the Association of Mature American Citizens, a group of 7 organizations on HR 3463, and the Blue Cross Blue Shield Association.
No objection.
Without objection, so ordered. You have a UC request.
Mr. Chairman, we also have some, submit for the record, letters from American Patient Estate County and Municipal Employees, the AFL-CIO, and I think our ARP sent us both the same letter, and the Alliance on Retired Americans. I'd like to ask unanimous consent to place in the record.
Without objection, so ordered. This time I'll introduce our panel of experts. We have 3 witnesses. I'll introduce them in the order of their testimony. Your written statements will be made a part of the record. You'll be each given 5 minutes to summarize your testimony. On our panel today, we have first Ms. Grace Marie Turner, founder, president, and trustee of the Galen Institute. Secondly, Mr. Douglas Holtz-Eakin, president of the American Action Forum. And finally, Ms. Sarah Collins, vice president of Health Coverage and Access Commonwealth Fund. Thank you very much for coming today. And at this point, Ms. Turner, you're recognized for 5 minutes for your summary.
Thank you, Chairman Pitts. Thank you, Ranking Member Green and members of the committee, for the opportunity to testify today on legislation that I believe would advance patient solutions to lower costs and better care. The ACA was designed to provide people with choices of private insurance, with states in the forefront of organizing the new system of coverage. States have had decades of experience in regulating health insurance, but a battery of ACA rules really overrides these state laws and has been that have been forged by decades of experience, and I believe really threaten the future of the ACA and its stability. For health insurance to attract customers, policies must be affordable, and everyone in the pool must pay their premiums over time so that their insurance coverage is there to pay their bills. If people only purchase health insurance when they need expensive care, the pools break down. It would be like allowing a family to purchase health insurance only when their house is on fire. Too few younger people purchasing health insurance. Purchase health insurance, costs will soar, and many of the young people will continue to drop out, increasing coverage for everyone. And that's one of the problems, I believe, with the age rating provisions in the ACA. Under these rules, insurers can charge their oldest policyholders no more than 3 times their youngest customers. But the average 64-year-old consumes 6 times more in dollar value than the average, and health costs, than the average 21-year-old. One of the top experts on the workings of the ACA is Timothy Yost. He noted early on that age rating compression is going to force younger people to pay more in the individual market as older individuals pay less, making insurance too expensive for younger people. And we need people, not just the 26-year-olds, but people that are up to 35, 40 years old in these pools. They drop out, and it means that health insurance actually costs more for older people as we wind up seeing a spiral. Likewise, the special enrollment verification, designed to help people, as you said, Mr. Green, to obtain health insurance coverage through major life events. But we're finding that more and more people are purchasing health insurance when they need medical care and then dropping it after they receive the medical services they need. This really undermines the concept of insurance. The claim cost, according to the actuarial firm Oliver Wyman, found that in the first 3 months in 2014 for people enrolling in the special enrollment periods, their claims costs were 24% higher than those who had enrolled during the regular enrollment period. In 2015, the difference increased to 41%. And these people are more than twice as likely to drop their policies after a short period of time. The administration has indeed taken preliminary steps to verify eligibility, but more needs to be done. I commend Congresswoman Marsha Blackburn for taking the lead on legislation to verify the expected significant increases in many places in 2017 for premium increases, and talking with experts and actuaries from Geisinger, for example, about why this is happening. And they are finding that people are gaming the system also through these grace periods. The law allows people to stop paying their premiums and still obtain coverage for another 90 days. Unfortunately, the incentives are basically designed to undermine the concept of real insurance. McKinsey & Company found that nearly a quarter of consumers stopped payment on their premiums in 2015, yet most repurchased a plan in the exchange the next year, many of them in the same plans, without the need to pay their back premiums. Insurers must build the cost of this non-payment of premiums into their costs for the following year, and this rises premium costs for everyone. Additionally, doctors and hospitals are on the hook to continue to provide coverage even for those patients who are no longer insured. Representative Flores's legislation would end this abuse by aligning the grace period for non-payment of premiums before coverage ends with grace periods under state law. A 30-day rule would provide greater incentive for people to keep and maintain coverage, basically the standard in state law, before the ACA overruled this legislation. Also, the failed state health exchanges, I think, is really an important issue to address. I know that your committee has issued a report misleading Congress on this particular issue, focusing on the testimony by acting CMS Administrator Andy Slavitt. States have decided that they can sue their IT managers who set up their websites when their websites have failed, and then they want to keep that money. That's really an abuse of taxpayer dollars. The federal government spent $5.5 billion in helping these states to set up their own exchanges. Oregon received approximately $305 million to establish an exchange. If it wins this lawsuit, it wants to keep the money. That's really not something that serves taxpayers well. And then finally, I also commend Representative Morgan and also Representative DeGette for your legislation, the bipartisan legislation, to address the issue of really streamlining and unifying the dental plans for pediatric dental care. Thank you, Mr. Chairman. I look forward to your questions.
Chair thanks the gentlelady. Now recognizes Mr. Holsegan, 5 minutes for his summary.
Thank you, Chairman Pitts, Ranking Member Green, and members of the committee for the privilege of being here to discuss these 5 proposals to make changes to the Affordable Care Act in the interest of having state insurance